Can you guys hear me?
أيوة دكتورة we hear you.
Okay, I'm going to start. It's already 1:05. So good afternoon, everyone. My topic is about reoperative valve surgery. So an outline of my presentation today, we'll have a brief introduction. Then we'll talk briefly about mechanical versus biological valves, then the risk factors of surgery. We'll talk a little bit about imaging, then moving on to aortic valve replacement, mitral valve replacement, and then finally tricuspid valve replacement. So as an introduction, operations, they most commonly involve structural deterioration of a bioprosthesis or the progression of a native valve disease. They are difficult than the primary operation because of adhesions around the heart and the presence of a more advanced cardiac pathology and the existence of a more frequent comorbidities such as pulmonary hypertension. So reoperative valve surgery considerably has a higher opportunity than the primary valve surgery. Reductions in the operative risk and postoperative morbidity by proper use of deep hypothermic cardiac arrest, and in addition, the use of peripheral cannulation technique. Bypass prior to re-entry, it prevents injury to the right ventricle or patent coronary artery bypass grafting during reoperative sternotomy. And replacement of a bioprosthetic failure remains a significant factor that has to be considered in the selection of valve type for implantation. So mechanical versus biological valves, each individual patient, depending on age, life expectancy, lifestyle, valve size, and cardiac, as well as non-cardiac comorbidities, taken into consideration. Some studies comparing the long-term outcome between biological and mechanical aortic prosthesis have yielded similar results, but with regard to overall valve-related complication. However, the most recent large studies have documented that anticoagulant-related bleeding with mechanical valves must be balanced against the life expectancy and the risk of biological valve replacement. Bioprosthetic valves are known to undergo a time-dependent process of structural deterioration that we all know, and that results in freedom of reoperation of 80% at 15 years, and also the benefit of valve-in-valve. Moving to mechanical prostheses, they usually are selected for younger recipients because of their proven durability over time and the risk of anticoagulant-related as thromboembolic events. In these valves, it's not trivial and depends on valve design, structural materials, and host-related interaction. In a 12-year study documented severe bleeding complication in 18.6 versus 7.1 respectively. Moreover, although endocarditis, dehiscence, paravalvular leak, and pannus formation with both the biological and the mechanical valves, the acute prosthetic thrombosis is exclusively a complication of the mechanical valves. Mechanical valve durability with these associated risks cannot be ignored and must be weighed against the anticipated rate of tissue valve failure and the need of reoperation. So the risk factors: reoperative 7% for the second operation and 14% for the third operation. Operative mortality for the first operation in a study that showed the total of 530 patients was 5.9% in the aortic position and 19.6% in the mitral position. In the aortic position, the operative mortality was 2.4 for patients presenting class 1, 1.6% for patients presenting with NIHA class 2, and 6.3% for patients presenting with NIHA class 3. And finally, 20% for patients coming with NIHA class 4 symptoms, emphasizing the significance for early referral. Regarding the urgency of the surgery, the mortality for elective mitral valve reoperation was 1.4%, and for urgent procedures, 8%, and for emergency procedures, 37%. In the Jones and colleagues series, mortality increased from 3% for reoperation on a new valve site to 10% for prosthetic valve dysfunction or periprosthetic leak, and mortality was highest, 29% for associated endocarditis or valve thrombosis. 136 patients in their study requiring re-replacement for prosthetic valves. Mortality was 26% for re-replacement of a mechanical valve and compared with 8% for re-replacement of a tissue valve. The authors concluded, through multivariable analysis, that significant predictors of mortality were was the year of reoperation, the patient's age, the indication for surgery, concomitant CABG, and the replacement of a mechanical rather than a tissue valve. So this table that they put in the book summarizes the risk factors. The first one being advanced age. The second one is impaired ejection fraction, congestive heart failure, or advanced preoperative functional class. Then afterwards, the urgency of operation or unstable status preoperatively, preoperative shock, concomitant CABG, or the presence of a previous bypass graft, valve endocarditis, surgery for perivalvular leak, valve thrombosis or prosthetic dysfunction, renal dysfunction, and finally, chronic obstructive pulmonary disease. So preoperative imaging in reoperative valve surgery, the standard preoperative coronary angiography and chest X-ray is usually uninformative about the anatomic relationship of these vital structures with the sternum. So a retrospective ECG-gated CT scanning has arisen as the modality of choice to assess not only the heart's location in relationship to the sternum, but also the graft's location and the patency of the graft. Preoperative CT scan will lead to a modification of surgical approach. 20% of patients who are undergoing redo cardiac surgery. So moving to the reoperative aortic valve surgery, first of all, the presence of a well-established contraindication to anticoagulation. Second, having the inability to monitor the prothrombin levels adequately. And then patients whose survival was limited and more dependent on a non-valve related issue. Emergency reoperation yields a higher early mortality rate from 25 to 44%. And the incidence of a Lima injury in the literature varies from 5 to 9% and is associated with a 40% risk of preoperative MI and a 50% mortality rate. The most traditional approach involves re-sternotomy, dissection of the Lima graft, and occlusion of the patent graft with a small bulldog, and then aortic cross clamping. The advantage of this strategy is short bypass time, maximizing uniform without cardioplegia, washout, but with an obvious risk of Lima injury during dissection. The no dissection surgical technique, in which the graft is left unclamped with the use of a deep hyperthermic cardioplegic arrest. The advantage of minimizing but not eliminating graft injury, and its main disadvantage is that an unclamped Lima graft can lead to poor uneven myocardial protection because of cardioplegia without washout from the Lima territory. Another disadvantage is poor visualization due to continuous flow through the Lima. It's worth mentioning that other strategy of handling the patent Lima graft involves deep hyperthermic circulatory arrest without controlling the graft or aortic cross clamping. This technique is indicated in patients with porcelain aortas. The no dissection technique with hyperthermic cardioplegic arrest is a preferred approach for the redo AVR in patients with a patent Lima graft, and several studies have documented the safety of this method without any increased risk of preoperative mortality. So moving to the conventional re-sternotomy, anterior mediastinal structures like the RV and the aorta have to be taken into consideration. Second, CT scan. And then third is the femoral bypass should be performed before re-sternotomy. Then for opening and oscillating, not a reciprocating bone saw. Afterwards, the Army-Navy retractor placed inferiorly in line with the sternotomy can be used in the wound during opening of the posterior table of the sternum. Bilateral pleural spaces are better to be open. The pericardial dissection plane from cardiophrenic angle. Then cephalic dissection should start with freeing the innominate vein before spreading the retractor to avoid this injury. Further dissection then is carried down to the SVC, being careful not to note the location of the right phrenic nerve. Dense adhesions in the right atrial appendage and avoid the area where the aorta opposes the pulmonary artery is another site of potential injury. Small ventricular or atrial laceration should not be attempted before releasing the tension of the surrounding adhesion. Repair of great vessels injury or severe injury is best done when on bypass. Severe active hemorrhage used during a second sternotomy usually is caused by adherence of the heart or the great vessels to the posterior sternum, and prevention of this complication by interposition of pericardium or other mediastinal tissue. The incidence of hemorrhage is between 2 to 6% per patient reoperation. In a report of 552 patients who had undergone reoperative prosthetic valve surgery, 23 patients, 4%, had complications related directly just to the sternal opening. Of these, 5 patients had injury to the right atrium, 7 patients had injury, lacerated RV, 9 patients had aortic injury, and 2 patients had a previously placed coronary artery graft. 23 complications occurred during the first reoperation. And the first death involved division of a previously placed coronary artery graft during re-entry. The second death was caused by laceration of the aorta with subsequent excessive sanguine. So what if major hemorrhage does happen? Resternotomy should be abandoned and the chest should be reapproximated by pushing towards the midline. The patient should be heparinized immediately, arterial and venous cannulation. Blood loss from the resternotomy should be aspirated with the cardiotomy section and returned to the pump. Once bypass has been established, core cooling should be commenced with anticipation of the need of circulatory arrest. So moving to the valve replacement after homograft / root / allograft. It is expected that about 1/3 of patients younger than 40 years of age will require aortic valve replacement within 12 years of homograft replacement. The feasibility of aortic valve replacement after full root replacement with a homograft in a series of 15 patients. Full root, mini root, and subcoronary techniques were all amenable to valve replacement. Homograft replacement nonetheless is performed, but it's much less common, and hospital mortality varies widely across many centers, ranging between 2.5 and 15%. Then moving to the reoperative mitral valve surgery. So median sternotomy, right thoracotomy, left thoracotomy, and transverse sternotomy can all be used. But the left thoracotomy has been used in the recent years to gain access to the mitral valve in situations in which a right thoracotomy is pre-occluded, like in cases the patient has a mastectomy or radiation or pleurodesis previously. This incision is made through the fourth intercostal space and the left pleural cavity is entered in the standard fashion. Surgery is performed under defibrillatory arrest or on the beating heart technique. Importance, the mitral valve orientation is noted to be upside down with this approach, with the posterior annulus found anteriorly. Thompson and colleagues recently reported 125 patients undergoing this technique. Were in NEHA class 3 or 4, and 28% had undergone 2 or more sternotomies. 30-day mortality was 6.4 with low complication. A bilateral anterior thoracotomy, which is the transverse sternotomy carried out through the femoral intercostal space, also has been described, but rarely used today. This incision transects the sternum transversely, requiring ligation of both internal mammary arteries. So for the mitral views, the standard left atriotomy with blunt dissection of the interatrial groove, also known as the Sundergaard groove, allowing the right atrium to be retracted medially and anteriorly. The right superior pulmonary vein and its junction with the left atrium is then exposed, and the left atrium is opened at the midpoint between the right superior pulmonary vein insertion. This incision is extended longitudinally, both superiorly and inferiorly, to give enough exposure of the mitral valve. Then the right atrial transeptal approach has become popular in the recent years, especially in reoperative valve surgery. So after opening the right atrium, the interatrial septum is incised, starting at the fossa ovalis and moving vertically upward for a few centimeters. Here you can see the that we talked about first, the left atrium, the Sundergaard groove approach. The left atrium enlarges to the right, increasing visualization from the right thoracotomy approach. The interatrial groove, known as the Sundergaard groove, is dissected approximately 1 centimeter deep down to the left atrial wall. The purse string suture is placed in the non-dissected area. This prevents tearing of the dissected left atrial wall when the sutures are tied down. The sternotomy technique, it has its own known risks, including injury or embolism of prior grafts, sternal dehiscence, excessive hemorrhage, and inadvertent cardiac injury. Atrial dilation can result in significant cardiomegaly, atrial thinning, and adherence of the heart to the posterior sternum. Patients undergoing prosthetic valve reoperation have a 4% incidence of complication directly related to sternal re-entry that can be in intraoperative death. Injury to a patent Lima graft has associated mortality rate approaching 50%. Manipulation of the patent but diseased saphenous vein graft can result in embolization into a native coronary circulation with the resulting morbidity and mortality. And patients with previous aortic valve replacements, difficult exposure of the mitral valve owing to the anterior fixation, and probably are best served by anterolateral thoracotomy approach. Here we have the transeptal approach that we mentioned earlier. So an atrial incision through the fossa of Vallis. When the right atrium is incised, an incision is made in the atrial septum Vallis. Retraction sutures on both the right atrium and the atrial septum of 2O silk then is used to elevate the septum to keep the left atrium open. Then afterwards, the mitral valve is exposed and the mitral valve replacement is done the same way. For closure, in the transeptal approach, the atrial septum is approximated with running 4O Prolene suture and is left till the aortic cross clamp is removed and air is evacuated. The left ventricle should be filled with fluid before removal of the cross clamp to help dislodgement of interventricular air, so de-airing technique. Once the cross clamp has been removed, air is evacuated vigorously from the left atrium to the septum or the left atrium itself, and the sutures are tied. The right atrium is then closed for Prolene suture in 2 layers, and TE has been very important in helping to monitor clearing of the air from intracardiac structure. We consider it mandatory in minimally invasive technique in which access to the entire cardiac structures is limited. Then moving to the right thoracotomy approach, the right anterolateral thoracotomy is one of the first surgical approaches to the mitral valve, and it has become a safe alternative to resternotomy for mitral valve replacement. Chest was entered through the bed of the 4th or 5th rib. The pericardium entered anterior to the phrenic nerve. If by TE there is atheroma grades of the descending aorta or arch less than 3, however, grades are greater than 3, then arterial cannulation is done via the right axillary artery. Venous cannulation was performed via the femoral vein with the tip of the cannula positioned between the SVC and the right atrium. In cases where requiring tricuspid valve surgery, an additional SVC cannula is used, while the femoral venous cannula is advanced at the IVC into the right atrium with help of the TE guidance. Perfusing blood via cannula, example like the left ventricular vent positioned across the mitral valve and into the left ventricle, will serve to displace residual air. Bypass time, blood loss, blood products usage, and Lima injury rates have also been lower in undergoing right thoracotomy than those with resternotomy. If CABG or significant AI is there, then medium sternotomy approach is better. 90 patients undergoing reoperative mitral valve surgery via minimally invasive right thoracotomy without aortic cross clamping showed excellent results. 2% operative mortality was lower than the STS predicted mortality of 7%. 3 patients renal failure post-operatively, with 1 patient requiring hemodialysis. 1 patient, 1% developed a post-operative stroke, and no patient suffered a post-operative MI. Some authors have noted that the distance to the mitral valve with the right thoracotomy approach at times can be limiting, and in their series, a 6-centimeter right anterolateral thoracotomy was used with the standard port access technique. 45% of patients underwent cardiac arrest with endoclamp technique, whereas the ventricular fibrillation was used in 55% of patients. Femoral cannulation was used in all the patients. The cohort of patients undergoing reoperative sternotomy or right anterolateral thoracotomy, patients undergoing the port access technique has a lower mortality and decreased transfusion requirements, but have a significant bypass times. All reoperative patients thought that the recovery from this approach was more rapid and less painful than the original sternotomy. So moving to the reoperative tricuspid valve surgery, In a Filsufi et al. Study, 72% of patients had a reoperation. The overall operative mortality in this group was 22%. Risk factors for mortality included urgent/emergent status, age greater than 50%, functional etiology, and elevated pulmonary artery pressure. Of the 60 survivors, 3% died during the follow-up. The authors concluded that patients requiring tricuspid valve replacements are at a high risk, frequently at end-stage functional class. Continued sepsis from seeding endocarditis, infective endocarditis bacteremia, despite antibiotic therapy, heart failure to tricuspid insufficiency, and recurrent life are indications to intervene surgically in the tricuspid valve endocarditis. Leads to late onset right-sided. It leads finally to late onset right-sided heart failure in the majority of patients. In a 20-year follow-up of the originally reported series of 55 patients with intractable right-sided who underwent tricuspid valvectomy without replacement, 2 patients died in the post-operative period owing to right-sided failure. 6 patients required prosthetic valve insertion 2 days to 13 years later for medical refractory right-sided heart failure. And of those who underwent reoperation, 4 died, and as such, severe hepatic congestion with the need of reoperative valve made this approach unattainable to some practitioners. An alternative treatment option is to perform valvectomy followed by delayed valve replacement 3 to 9 months later. So there was a table to summarize the technical consideration for reoperative valve surgery. The first one, you have to consider reoperation decline in the functional status of the patient, assess the RV/aortic proximity to the sternum preoperatively with a CT scan. Second is to consider alternative approach, especially when there is a patent graft, like the right thoracotomy for reoperative mitral valve replacement or mini sternotomy for reoperative aortic valve replacement. Thirdly, consider alternate cannulation technique to gain safe entry, like femoral or axillary. Then also address the Lima/LAD graft if present, dissect out or clamp it or cool and ignore it. Then consider ease of implantation of valve choice, example, a mechanical and homograft. Then use of the no-touch technique for the bypass graft. Then the use of a conservative myocardial protection strategy, antegrade and retrograde. Also consider systemic cooling. Finally, warm induction/final dose with hot shot. If using a hypothermic fibrillatory arrest, beware of the AI leading to LV distension and/or obscuring the operative field. The placement of external defibrillator pads, and consider the use of antifibrinolytic agents like Amicar. My reference is from Lawrence.
Assalamu alaikum. Thank you very much, Dr. Khulud. That was a very thorough review of reoperative valvular cardiac surgery. One important point that you mentioned, and I would like to summarize, and correct me if I'm mistaken. We are always asked about what should you do whenever you have an injury during a reoperative scenario. So you said that that you have to give the patient immediately heparin. You need to abandon the sternotomy and tamponade the bleeding by both sternal tables, and establish another access for cardiopulmonary bypass in order to have a bloodless field for repair. Is that all, or I forgot something?
Yes, I think that's it, and that's what I have seen actually in OR. This is what is usually done. Do you know anything else?
No. I'm just summarizing what you just said, because it's a very important thing to know, because always we are asked what should you do. I just want to add that sometimes you have to say that before you even start the redo sternotomy, you have to make sure that the blood is in the OR, and you have to have the anesthesia be alert with you at the time of the sternotomy with heparin ready to be administered in case la samah Allah something happens. And it is always safer for me, I think, in my opinion, if you're gonna go through redo surgery, is just to have to cannulate preferably before you do anything, especially for me if I'm gonna in the start of my career.
Right. Actually, I have seen consultants, they ask for the blood to be in the room before starting, just in case. And they coordinate this with the anesthesia.
Yeah, I remember if you are asked in an exam, you have to say this. Before I start, I have to make sure that the blood is in the room, heparin is ready, just in case, before starting. And the things that I summarized and you have mentioned very well in your presentation. Does anyone have anything to add to this point or to Dr. Khouloud's lecture?
Assalamu alaikum.
Alaikum assalam wa rahmatullahi wa barakatuh.
Thank you, Faisal. Just to add a few comments about reduced sternotomy. So I don't disagree with you about like being more conservative and going peripheral cannulation. And especially early in your career, nobody will fault you for this. And however, in real practice, you don't want to have, for example, to go on bypass and use the femoral cannulation, and then you're wasting this femoral cannulation, and then you switch back to central. Unless you want to perform the whole operation with peripheral cannulation, which you don't want because it's a retrograde flow. So the other option is to be safe. You can, early in your career, you can have a cut down. You can put your purse string in the femoral artery and the femoral vein and just leave them and go do your sternotomy.
I think that's what I meant, but I did not make it clear. I will just make the incision over the axillary and over the femoral and prepare everything in case something happens, because it's, for me, it's already hard while I am calm.
Yeah.
So I don't want to do it.
Yeah.
I don't want to do it during emergency.
Yeah, so you don't want to actually go and peripheral cannulation, like everything, just like femoral cut down. You can put your purse string without even giving heparin. You start your sternotomy and then see how it goes. And if you think it's very stuck on you or you have injured anything, it's easy to go just to the femoral and you cannulate, okay? It's very important to discuss with perfusionist about alternative cannulation. So if you think in the case of emergency, you're gonna go on femoral cannulation, you'd have to discuss with perfusionist what are the proper size of the cannula and have them ready. Because you don't want, in case of emergency, perfusionists are running away to try to grab the femoral cannulation or the femoral cannulas. As you are, for example, advancing in your career, you'll be more confident. So the second stage, rather than having the cut down, is to put wires. You can put arterial and venous wires, so just like art line, right? So it's secured and you have the line. So whenever there's an emergency, you can just like open, rewire again with the peripheral cannulation wires and do percutaneous cannulation.
The thing, Dr. Mariam, is I prefer, if I'm gonna do peripheral, the axillary, because it will give me the chance to give antegrade in case I need the deep hypothermic circulatory arrest.
Yeah, so it's two different techniques. Like if you're doing, for example, an arch and you want to circle rest and you think you're gonna be like having an open distal anastomosis, then the best cannulation site would be axillary. So yes, you would want to cut down the axilla, isolate the axillary artery and cannulate the axillary artery by sewing a graft. Before you go, like you can give 10,000 heparin and you can sew the graft and cannulate, and then you open the sternum. Okay. However, if you think that you don't need this, you're gonna, for example, do only aortic valve replacement and you're not gonna circle rest, but it's a reduced sternotomy. And from the safety perspective, you want to have an alternative cannulation site, then the best cannulation site and the easiest one in case of catastrophe is femoral. Arterial and venous.
Yeah, thank you very much, Dr.
Yeah, so it's only stages, and it's really like as you advance in your career, you would look at the CT and see how difficult is the reduced sternotomy. Some of them you can feel there's some space, and you feel confident that you won't need peripheral cannulation. However, I will advise, at least if you don't want to do cut down, you put lines. Arterial and venous, while anesthesia are, for example, putting the patient to sleep and putting a central line, just go and throw arch line and venous line and secure them. It will give you extra access. If you need them, it's easier to cannulate percutaneously. However, nobody, as I told you, nobody will fault you if you want to do cut down and be prepared from the beginning.
I understand. Thank you very much, Dr. Mariam.
You're welcome.
Dr. Riyad?
Yeah, Professor.
Are you ready for your lecture?
Yeah, ready. Yeah.
Can you please start your slides? Because we have 4 lectures today and we have a case discussion.
Okay. Let's start now. Assalamu alaikum. Riyad Al-Kharti, R3 at Kafafa. Anatomy and pathophysiology of tricuspid and pulmonary. Tricuspid valve consists of 3 leaflet, anterior, posterior, and septal, chordae tendineae, and 2 discrete papillary muscle, the fibrous tricuspid annulus, and the right atrial and right ventricular myocardium. The anterior leaflet is the largest, septal leaflet is smallest, and arises medially directly from tricuspid annulus above the interventricular septum. The posterior leaflet often has multiple scallops. Tricuspid annular sizing has been based on dimension of the septal leaflet. The anterior papillary muscle provides chordae to anterior and posterior leaflet, while the medial papillary muscle provides chordae to posterior and septal leaflet. The septal wall gives chordae to anterior and septal leaflet. There may be accessory chordal attachment to the right ventricular free wall and moderator band. Right ventricular dysfunction and dilation lead to chordal tethering, contributing to loss of the leaflet opposition. Dilation of the right ventricle result in tricuspid annular enlargement, primarily in anterior-posterior aspect, resulting in significant functional tricuspid regurgitation. During the cardiac cycle, there is approximate 20% reduction in annular circumference, 30% reduction in annular area with atrial systole. Healthy subject had non-planar elliptical shape tricuspid annulus with the posterior portion being lowest toward the right ventricular apex and anteroseptal portion the highest. Patient with FTR generally had a more planar annulus, which was dilated primarily in septolateral direction, resulting in more circular and flat shape, as compared with elliptical shape in healthy subjects. The most common presentation of TR is secondary to cardiac valvular pathology, mostly mitral valve disease, as pulmonary hypertension developed, leading to right ventricular dilatation. The tricuspid valve annulus will dilate. The circumference of annulus length primarily along attachment of the anterior and posterior leaflet. The septal leaflet is fixed between fibrous trigon, preventing lengthening. Progressive annular and ventricular dilatation, the chordal papillary muscle complex become functionally shortening, causing leaflet tethering. This combination prevents leaflet opposition, resulting in valvular incompetence. Eisenmenger syndrome and primary pulmonary hypertension lead to the same pathophysiology of progressive right ventricular dilatation, tricuspid annular enlargement, and valvular incompetence. A right ventricular infarction produces either disruption of papillary muscle or severe regional wall motion abnormality. Marfan syndrome and other variations of myxomatous disease affecting the mitral and tricuspid valve can lead to prolapsing leaflet, elongation of chordae or chordal rupture, producing valvular incompetence, dilated cardiomyopathy in late stage of biventricular failure, and pulmonary hypertension produce TR. Infectious endocarditis can destroy leaflet tissue, mostly in drug addict with staphylococcal infection. The carcinoid syndrome leads to the deposit of fibrous tissue in endocardium of valve cusp, cardiac chambers, intima of the great vessels, and coronary sinus. Effect of tricuspid permanent pacemaker or implantable cardiac defibrillator worsened by 1 grade or more. That TR worsening was more common with implantable cardiac defibrillator, than a permanent pacemaker. The current guidelines do not recommend lead extraction for patients with existing TR and trans tricuspid pacing lead. Tricuspid regurgitation, rheumatic disease of tricuspid valve is always associated with mitral valve involvement, and deformity of the tricuspid tissue results in tricuspid valve stenosis as well as regurgitation. Symptom of fatigue, weakness related in reduction cardiac output. AF is common, jugular vein distension is found. Right side heart failure lead to ascites, congestive hepatosplenomegaly, pulsatile liver, pleural effusion, and peripheral edema. In the late stage, these patients are worsened with cachexia, cyanosis, and jaundice. Hepatic cardiac cirrhosis can develop in neglected cases. Echo is routine used to assess severity of TR in clinical practice. Pulsed Doppler and color flow study help to identify systolic right ventricular to right atrial flow. The tricuspid valve is carcinoid syndrome is thickened with retracted leaflet fixed is in a semi-open position throughout cardiac cycle. Tricuspid stenosis, most commonly rheumatic, extremely rare, have to isolate TS because some degree of TR will be present. The anatomical features are similar to those of mitral stenosis with fusion and shortening of cordia and leaflet thickening. Fusion along the free edge and calcific deposit on the valve are found late in the disease. The majority of cases is in young women. The diastolic gradient between the right atrium and right ventricle is significantly elevated, even 2 to 5 millimeters per mercury mean pressure. As the right atrial pressure increases, venous congestion leads to distension of the jugular vein, ascites, pleural effusion, and peripheral edema. Over time, the right atrial wall thickness and atrial chamber dilated. Clinical features are consistent with reduced cardiac output, producing symptom of fatigue, malaise, significant liver engorgement, produce right upper quadrant tenderness with palpable liver with pre-systolic pulse, ascites, peripheral edema, and anasacra can default. Severe TS may mask or reduce pulmonary congestion of mitral stenosis, aiming to reduce blood flow to the left side of the heart. The low output state of the patient is prominent. Echo reveals the diagnostic features of diastolic dimming of thickening tricuspid valve leaflet, reduced leaflet mobility, and reduced orifice of the flow. The Doppler flow pattern across the tricuspid valve has prolonged slope antegrade flow. Functional tricuspid regurgitation, secondary tricuspid regurgitation, also called FTR, may become worse over time, leading to severe symptom, biventricular heart failure, and death. Pulmonary arterial hypertension from any cause is known to be associated with development of secondary tricuspid regurgitation. Increased pulmonary artery systolic pressure was independently associated with greater degree of TR. Other factors such as AF, pacemaker lead, and right heart enlargement were also important associated with TR severity. Surgical treatment of left side valvular lesion is not always adequate to resolve or prevent progressive TR. This is especially true when pulmonary hypertension persists. Pulmonary valve outlet portion and pulmonary valve. The outlet portion of right ventricle consists of infundibulum, circumferential muscular structure that support the leaflet of the pulmonary valve. Because of similar shape of pulmonary valve leaflet, this valve does not have annulus in traditional sense of ring-like attachment. The leaflet has similar attachment that across of musculoarterial junction in corresponding similar fashion. Instead of single annulus, 3 ring can distinguish anatomically in relation of to the pulmonary valve. Superior, the sinotubular ridge of pulmonary trunk mark level of peripheral opposition of the leaflet, the commissures. A second ring exists at a ventricular arterial junction. Third ring can construct by joining together the basal attachment of 3 leaflet to the infundibular muscle. None of these rings correspond to attachment leaflet. These similar attachments, which mark hemodynamic ventricular arterial junction, extend from the first ring across second down to the third and back in each cusp. Thank you.
Thank you very much, Dr. Riyad. That was a very thorough and short review of the anatomy and pathophysiology of the tricuspid and pulmonary valve. Thank you very much. I would just want to stress that the tricuspid valve, most of its pathology are functional. And unfortunately, the echo assessment of the tricuspid valve can be deceiving. I mean that by saying that most of the functional tricuspid valve are caused mainly by left valvular halt lesions. And some surgeons I have heard say that whenever you repair the left, you will just alleviate the right, and the tricuspid valve will improve tricuspid regurg. But I have seen in multiple cases and also read that that is the opposite is most of the time is true. Sometimes when you repair the left side, you overload the right ventricle and the tricuspid will be even more severe. I remember I have attended the case for a patient with severe rheumatic mitral stenosis, and she had mild to moderate TR according to her echo. Immediately after replacing her mitral valve and coming off pump, her TR has become severe. After I have discussed it with multiple of the consultants I am working with, I understood that once you have repaired this mitral regurg, sorry, it was not stenosis, you had more output that the RV has to deal with more. So your tricuspid had become more severe. So even in the guidelines and the book, they would recommend that you have to assess the tricuspid valve even with the mildest of regurgitation, and you have to be liberal with the repair. And I read also some of the surgeons, they don't even repair just by the regurgitant severity. They will measure the annulus of the tricuspid valve and decide upon that measurement whether to repair or not, because the tricuspid regurgitation can vary significantly pre-op and post-op, especially with the hypovolemia and the RV dysfunction, RV function variability intra and pre-operatively. Does anyone have to add anything to this topic, especially you, Dr. Mariam?
I don't have anything to add, but I just have one question, Dr. Faisal. I didn't quite understood when you said mitral regurgitation, when you elevate it, you increase the load on the RV. How? Yeah, I thought that with the regurgitation, you have increased afterload on the RV this way, but when you elevate it, this overload is gone.
Yeah, when you repair the mitral regurgitation, you reduce the afterload, right? But now you have more output towards the systemic circulation. And the systemic circulation will go back to the right side, which was not used to this amount of blood during the regurgitation. This will overload the RV. So you alleviated the afterload, but now you have more preload, which can dilate your RV and exacerbate your tricuspid regurgitation, especially when the tricuspid annulus is already dilated. That's the idea I understood from discussing this case. So tricuspid is unpredictable. You cannot just say, if I repair the left side, the right side will be less. Even if, intraoperatively, I have read some of the studies in Lawrence that they found that tricuspid regurgitation will progress. That's its natural process, and will lead to worse life quality and more survival. So it's better to be liberal with repair than to leave it, especially if it's moderate or more. I hope it's clear, the idea. Anything to be added? Okay. The third lecture is presented by me. It's about tricuspid valve repair and replacement and guidelines. I don't know if you would like to have a break for 5 minutes or we should continue.
We can have a break for 5 minutes. We'll get back, Faisal.
Okay, so 5 minutes break until 1:55, and then we shall resume our activity. Hello? Can you see my slides?
Yes, we can see them.
Okay, great. Okay, assalamu alaikum everyone. Today my topic is about tricuspid valve repair and replacement. I will talk about the repair and replacement technique, and also I will talk about the guidelines and the indication for tricuspid valve intervention. I prepared a couple of slides about the anatomy and the pathophysiology, but Dr. Riyad Al-Harthi has done, mashallah, a great job. So I'll just go over a couple of the slides quickly, and then I will dive into my main topic. So regard to the anatomy, which is the most important thing, as you can see here, as you can see here, this is the right atrial chamber, and this is your surgical view of the tricuspid valve. You can see the relationship of the conduction system in relation to the tricuspid valve. You have here the AV node and the bundle of His perforating here the membranous septum and going toward the ventricular chambers. You can see here the coronary sinus, and here you can see the ostium of the IVC, and this is the fossa ovalis. Sorry, another important thing about the anatomy is the important relationship of the tricuspid valve to adjacent structures, which is an important thing to know in order to know the possible complications that can happen during a tricuspid valve surgery. One possible thing is that you can injure the conduction system, and you can see here that the AV node starts almost the AV node is almost at the center of the septal leaflet, and it goes parallel to it until the bundle of His perforate the membranous septum. And you can see here also the tricuspid valve is very close to the aortic valve, and any deep sutures, especially at the first third of the anterior leaflet or the anterior septal commissure, you can injure the aortic leaflets and aortic sinuses. You can see this is something, a diagram that Dr. Riyad showed, that most of the dilatation happened toward the antero-posterior commissure or anterior and posterior leaflets. And this is because this side of the valve is anchored to the right trigone, while this one is toward the RV free wall. Another important relation that I have to mention, sorry, I've lost the slide. Yeah, here. This is the interventricular septum. You have to understand that the tricuspid valve attachment to the annulus of the tricuspid valve is lower than the mitral valve. So there is an area between the right atrium and the left atrium where it is actually between the right atrium and the LV. There is a communication. This is where the membranous septum is situated, and it divides the LV from the RA. And whenever you hear that there is an LV-RA shunt, it usually happens in this side. So these are the most important points I want to mention in the anatomy. Last thing, I will just mention the echo grading of the tricuspid regurg and tricuspid stenosis before we delve into the guidelines and the indications. So for tricuspid valve regurgitation, the main parameter are the RV and the right atrium and the IVC sizes. Also, they use the jet area and the central jet ratio, and the vena contracta width, and the Pisa radius and the hepatic vein flow. So it is considered severe when the jet area is more than 10, and when the vena contracta is more than 0.7, and the Pisa radius is more than 0.9, and the systolic reversal, there is a systolic reversal in the hepatic vein flow. This is also from the European guidelines. There are multiple parameters, but the most important are the quantitative, which is the one we mostly see. There is the EROA, which is the effective regurgitant orifice area. It is a millimeter squared. When it is more than 40, this is severe. When the regurgitant volume is more than 45 or 45, this is also severe. And when there is an enlargement of the cardiac chamber or vessels, this is also considered severe. For the tricuspid stenosis, the severity of the stenosis is assessed by measuring the transvalvular gradient and the valve orifice area. But the number I have seen in the guidelines is whenever the gradient is 5 or more millimeters mercury, this is the definition of at a normal heart rate. This is the definition of severe tricuspid valve stenosis. Important thing is in all patients who are being assessed for tricuspid intervention, you have to assess for the presence of PFO or ASD, so that it will be repaired during the surgery to prevent further future paradoxical embolism. Now I will start with the main topic of my presentation, which is the indication for surgical intervention for the tricuspid valve. I summarized the American Heart Association and the European Society of Cardiology guidelines. So first, for tricuspid regurgitation, you can see here for the American Heart Association stages TR into 3 stages. Stage B is when there is a progressive tricuspid regurg with the central jet less than 50% of the right atrium and ERO less than 0.40 centimeters squared, and there are no hemodynamic consequences or symptoms. Stage C, when it's asymptomatic severe, that means a central jet with that is taking more than 50% of the right atrium, vena contracta more than 0.7, and ERO more than 0.4 centimeters squared, and regurgitant volume more than 45 milliliter. Symptomatic is the same, but with symptoms. So for indications for and guidelines for medical treatments in patients with tricuspid regurgitation, it is not very clear. Most of the guidelines, as you can see, are recommendations are class 2A. The first one, that in patients with signs and symptoms of right-side heart failure due to severe TR, meaning stage C and D, diuretic can be useful. In stage 2A, in as a class of recommendation 2, in patient with signs and symptoms of right-side heart failure due to secondary TR, therapies to treat the primary cause of heart failure, like pulmonary vasodilator in patients with pulmonary hypertension, guideline directed medical therapy for patients with heart failure due to reduced ejection fraction, or patients who have atrial fibrillation, which is a common cause of secondary tricuspid regurgitation, are also can be used in such patients. Other medications that can be used are like aldosterone antagonists, like ACE and ARBs may be added for such patients. Indication timing for intervention, first as a class 1 in patients with severe TR as stage C and D with undergoing left-sided valve surgery, tricuspid valve surgery is recommended. As a class 2A in patient with progressive TR as stage B undergoing left-sided valve surgery, tricuspid valve surgery can be beneficial in the following condition: tricuspid annular dilatation, annulus in diastolic diameter of more than 4 centimeters, and prior signs and symptoms of right-sided heart failure. So in patient with going for left-sided valve surgery and have less than severe TR but have dilated annulus or history of heart failure, right-sided heart failure symptoms, it is class 2A to repair the valve. It is class 2A also in patient with signs and symptoms of right-sided heart failure and severe primary TR. Isolated tricuspid valve surgery can be beneficial in patient with symptoms and severe primary TR. See, even in primary TR and symptomatic, still it's not class 1, it's still class 2A. In patients with signs and symptoms of right-sided heart failure, severe isolated secondary TR attributable to annular dilatation or pulmonary in the absence of pulmonary hypertension or left-sided disease, and they are poorly responsive to medical therapy, isolated tricuspid valve surgery can be beneficial. As class 2B, asymptomatic with severe primary TR and progressive RV dilatation or systolic dysfunction, isolated tricuspid valve surgery may be considered. Patient with signs and symptoms of right-sided heart failure, severe TR, who have undergone previous left-sided valve surgery, reoperation with isolated tricuspid valve surgery may be considered in the absence of severe pulmonary hypertension or severe RV systolic dysfunction. The reason this is not a very strong recommendation is because it's usually a high risk due to it's a reoperation setting, and also because such patients are usually referred very late, where the RV function has been affected significantly. So this is a decision tree for such patient. If the patient has severe, you have to see whether whether the patient is going to undergo a left-sided valve surgery, then it's class 1. If the patient is has a right heart failure, if it's primary TR, it's class 2. If it is 2A, if it has secondary TR and cannot be controlled by medical treatment, and he has annular dilatation without increased pulmonary artery pressure, it's class 2A. If he has prior left-sided valve surgery and he's going for a reoperation with no pulmonary hypertension or RV systolic dysfunction, it's class 2B. If the patient is asymptomatic with primary TR, with progressive RV dilatation or systolic dysfunction, it's class 2B to do for him TB surgery. If the patient has progressive TR at the time of left-sided valve surgery with annular dilatation of more than 4 centimeters, and history of prior symptoms of right heart failure, it's class 2A. In the guidelines of European Society of Cardiology in 2021, they divided their guidelines into primary and secondary tricuspid regurgitation. In primary tricuspid regurgitation, surgery is recommended in patients with severe primary TR undergoing left-sided valve surgery. Surgery is also recommended as a class 1 in symptomatic patient with isolated severe primary tricuspid regurgitation without severe RV dysfunction. Surgery should be considered in patient with moderate primary tricuspid regurgitation undergoing left-sided valve surgery. This is class 2A. Surgery should be considered in asymptomatic or mildly symptomatic patient with isolated severe primary tricuspid regurgitation and RV dilatation who are appropriate for surgery, class 2A. So severe primary with left heart surgery, or symptomatic and have severe TR can also go isolated surgery as class 1 if they don't have RV dysfunction. For secondary TR, it's class 1 to do surgery for patients with severe secondary TR who are undergoing left heart surgery. This is the same as the American Heart Association. Also, the surgery should be considered in patients with mild to moderate secondary TR with either dilated annulus, meaning more than 40 or more millimeter, or more than 21 millimeter per meter squared by 2D echo, who are also undergoing left heart surgery. And this is what I mentioned to you. Sometimes, even for mild or moderate, going for left heart, you don't look at the echo, you look at the annulus diameter. Surgery should also be considered in patients with severe secondary TR with or without previous left-sided surgery who are symptomatic or have RV dilatation. Absence of severe RV or LV dysfunction and severe pulmonary vascular disease or vascular disease hypertension. This is class 2A. Transcatheter treatment of symptomatic secondary TR, severe TR may be considered an inoperable patient at a heart valve center with expertise in the treatment of tricuspid valve disease. This is also a decision tree from the European Society of Cardiology. You can take a screenshot and look at it at your leisure. For the guidelines of tricuspid stenosis, the American Heart Association did not have any guidelines the guidelines they published in 2020 for tricuspid stenosis, but the European Society, they had 2 recommendations. Surgery is recommended for symptomatic patients with severe stenosis. This is class 1, and surgery is recommended in patients with severe tricuspid stenosis undergoing left-sided valve intervention, and that's class 1. This is a study that was mentioned in Lawrence, and it is has a very interesting finding. It was done by Dreyfus and his colleagues. They studied around 300 patients, and they wanted to know whether surgical repair of tricuspid valve, regardless of the severity on echo, while in the setting of left-sided valve surgery, whether it has a benefit or not. So they randomized 300 patients who are undergoing mitral valve surgery to either undergo the tricuspid valve repair if their annulus is more than 70 millimeter, or just isolated mitral valve replacement with no intervention on the tricuspid. That they found that in the tricuspid regurgitation increased by more than 2 grades in the patient whom they have not done for them the repair, and it increased in 48% of them. While in the patients who they have done for them the tricuspid repair, only 2% had progression in their tricuspid regurgitation. And the authors of this study, they concluded that remodeling annuloplasty of the tricuspid valve based on tricuspid dilatation improved the functional status. In this study, they did not find any difference in mortality and survival between the two groups, but they found difference in the tricuspid regurg severity and also their quality of life due to their symptoms. This is regarding the indication. Now I will talk about the surgical technique and some of the tips regarding repair or replacement. So for exposure of the tricuspid valve, you can access the tricuspid, the pericardium either through a full sternotomy or partial lower sternotomy or right mini thoracotomy, especially in the setting of redo. Cannulation, you have the option of doing it. You have to do it by cable with cable snares in order to isolate the right atrium and have a bloodless field. Either you can do it through the right atrium, or if you are doing it minimally invasive through a mini thoracotomy, you can have femoral and internal jugular cannulas going to the SVC and IVC. Arterial cannulation, you can do it either direct or femoral artery if you're doing it as a minimally invasive surgery. Right mini thoracotomy during the redo is advantageous because you are avoiding the adhesions at the site of the previous resternotomy. So you're minimizing the risk of injury. So myocardial protection, it can be done with cardioplegic arrest, either antegrade or retrograde. The tricuspid valve alone can be done on pump, but with a beating heart. The advantage of this technique is that when you are putting your suture, you can detect any conduction abnormality during putting the annular suture. But in the setting of concomitant mitral valve intervention, you can arrest the heart and cool the patient. You can approach the mitral valve either through the right atrium, then transseptal, or you can do the mitral through left atrial incision in the Sundergaard groove, and then open the right atrium and do the surgery. One thing you can do in such surgeries to reduce your cross-clamp time is to do your mitral on pump, arrested heart, then de-air the patient. Once the heart starts beating, remove your cross clamp and you can do your tricuspid valve on pump while the heart is beating. So that will reduce your cross clamp time and your ischemia time. So these are the approaches to the right atrium. I took this picture from Carpentier reconstructive valve book, reconstructive valve surgery book. There are multiple. You have the classic incision, which is the transverse one, and you have the vertical incision, and you have this half a circle incision around the IVC cannula. For Carpentier, he said that in his book that he prefers this incision because the reason he likes it is because it minimizes injury to the conduction pathway, meaning that you are not close to the sinoatrial node, and it provides more direct visualization of the tricuspid valve. After you did your right atriotomy, you have to expose the valve and assess it. You have to carefully inspect the right atrium to detect any endocardial thickening, thrombus formation, or jet lesions. These jet lesions will give you an idea or a hint about the valvular pathology. The interatrial septum is carefully inspected to detect any patent foramen ovale, which could be the cause of paroxysmal emboli in the future in case if you do not repair it. And also you have the tricuspid valve has to be examined to detect any valvular lesion. You have to detect the whole valvular apparatus. The annulus, you have to measure it. You have to check the leaflet for any injury, and the subvalvular apparatus, and like the chorda tendineae and the papillary muscle. And as I mentioned, you have to measure the tricuspid valve, tricuspid annulus, to measure the tricuspid annulus. One historical way of assessing the tricuspid valve, which was done in before the echo being available readily in every OR, is that they would put their finger through the right atrial purse string and insert it into the tricuspid valve, 2-finger. If more than 2 fingers can enter, and once you withdraw your fingers and you can feel regurgitant flow on your finger, this is significant tricuspid regurg. But now they are no longer doing this because of the presence of echo. So before you start your repair, there are 3 fundamental principles you have to bear in mind. You first have to restore or preserve full leaflet mobility. You have to provide a large surface of leaflet coaptation, and you have to remodel and stabilize the annulus. These are for the repair of the tricuspid valve. So there are many techniques. There is the mainstay, which is the annuloplasty ring. There is the bicuspidization and the de Vega. And there are others, but these are the most well-known techniques. This is a summary of the techniques throughout the history. You can see here, this is the de Vega technique. This is the annuloplasty technique. And this is the bicuspidization technique. Called bicuspidization because you change the valve from tricuspid valve to a bicuspid valve. So tricuspid valve annuloplasty, which is the first technique. First, the rings that are used in this surgery are different from the mitral valve rings because they have an oval shape, which replicate the systolic configuration of the normal tricuspid orifice. The ring of the tricuspid valve is usually deficient, as you can see in this picture, at the location of the AV conduction system to avoid any inadvertent injury. Also, tricuspid valve rings can be rigid or flexible. Also, there are available bands. This is a summary of the types of prosthesis that can be used for annuloplasty. I took it from Lawrence. There are rigid rings like Carpentier and Edwards and MC3 rings. There are flexible rings like the Duran ring. And there are flexible bands like the Cosgrove annuloplasty and the Medtronic Triad Adams annuloplasty ring. This is the one I have seen in our hospital. So which type of ring you have to select? The size of the prosthetic ring is chosen according to the surface area of the leaflet tissue. And there are 2 measurements that were mentioned by Carpentier. The first measurement is of the base of the septal leaflet. And the second one is the surface area of the leaflet tissue attached to the chordae arising from the anterior papillary muscle. I will show you a picture how to measure this measurement. And according to Carpentier, this is the most important one. In Lawrence, they only mentioned the measurement of the base of the septal leaflet. So these are the 2 techniques. The way he described it is that you have to put a stitch on the post-through septal commissure in order to help you retract the valve, and then use your measurement device. You put the 2 notches in the measurement device, one on the anteroseptal commissure and one on your suture. Okay, after taking this measurement, you have to do the second measurement, which is the leaflet tissue attached to the anterior papillary muscle. So you use, as you can see here, a nerve hook or a right angle, and you pull all the leaflet tissue that is attached to the anterior papillary muscle. And then use the measurement device. If the area of leaflet tissue is similar to the measurement device you have used, this is the right size. If the area is bigger than the one you first used, then you have to choose a bigger ring size. I hope it's clear. So how should you implant your ring? According to Carpentier, you have to use a 3O horizontal mattress sutures that should be placed equidistant points around the tricuspid annulus. He said that the first septal sutures should be placed posterior to the midline of the septal leaflet. So at the midline, I will show you now a picture here. You start from the midline of the posterior leaflet. And your suture should not be at the annulus. As you can see in this diagram, the septal sutures are very close to the attachment line, to the hinge, while the other sutures are 2 millimeters away, meaning on the annulus. The reason this is done is to avoid injury to the conductive system. So to go back to my slide, so as I said, through the very hinge in the septal leaflet, then you follow the septal mattress suture in a counterclockwise, the same manner toward the posterior septal commissure. The mattress sutures corresponding to the posterior anterior leaflet are placed within the annulus, as I have showed you in the picture. You should be careful around the aortic segment of the annulus, not to injure the aortic root. One advice to avoid injury in any valve is your needle has to be in a right angle toward the RV. You should not take it perpendicular. It should go parallel to the annulus. It should be perpendicular to the RV and back into the annulus. Never take it your angle of the needle like more acute. It should be perpendicular at a right angle to the annulus toward the RV, then back to the annulus to avoid any injury. That's okay. The sutures are then passed through the sewing band you have selected previously. Your prosthetic ring is lowered into position. During placement of the suture during the ring, Lawrence mentions that the spacing of your sutures on the ring should be at a smaller distance than the one on the annulus in order to cause a persistring effect to make the size of the tricuspid smaller. While Carpentier says that on the septal leaflet, it should be the same distance, but the posterior and the anterior should have smaller distance. I will show you now. So the normal geometry of the closure line is tested by using a bulb syringe, the saline flush. A regular line closure indicates that the large surface coaptation has been restored. If you do it aggressively, like you reduce the annulus aggressively with the tricuspid valve, this can lead to ring dehiscence, which can happen due to excessive tension on the tenuous tricuspid valve annular tissue. As you can see here, this is what I mentioned to you. Your distance on the ring of your sutures on the ring should be smaller than the ones on the annulus in order to reduce the size of the annulus. But as you can see here, the septal sutures are the same distance as in the annulus, but here they are a little bit smaller. And that's what he mentions in his book. But in Lawrence, all should be smaller. Other techniques, I will not spend much time on these techniques because I rarely saw them used. Like the De Vega, I only saw it once. And also their outcome is inferior to the annuloplasty ring. So the first technique is the De Vega technique. It partially replicates the annulus, reducing annular circumference and diameter. Usually a suture, I will show you a picture while I'm explaining. You can see here that a double loaded suture is used. You start first from the anteroseptal commissure and go around the tricuspid valve all the way to the posteroseptal commissure. And then you put the other needle of the suture through a pledget and then go again in the outer part of that first suture. Then through a pledget, you put both needle and then you tie your stitch. You tie your stitch until you have the size you desire. How do you determine the size? In Lawrence, it mentions two techniques. One historic, they used to put 2 fingers. And once the valve is snug around your 2 fingers, that means that's the proper size. Another thing, you can use the ring sizer as a template. That's 2 technique. A third technique, which I have seen one surgeon, an old and a senior surgeon in our hospital, he used a syringe, you know, the plastic syringe. He took like a 60 millimeter, if I remember correctly, syringe, like a medium diameter one, and he placed it inside the tricuspid. He tightened his suture until the valve was snug around that syringe, and then he tied his suture. The other technique is the bicuspidization technique, which is to change the valve from tricuspid to bicuspid by plicating the posterior leaflet. As you can see, it is performed by placement of a mattress suture from the center of the posterior leaflet to the commissure between the septal and posterior leaflet. As an option to support this technique, you can also use a flexible ring. These usually techniques are old, and usually they are only used when the tissue of the tricuspid annulus is friable and cannot hold enough sutures for a ring or the tension of a ring. There are many other repair techniques mentioned in the Carpentier book, depending on the pathology, especially for primary, like here for ruptured chordae. You can see here for excessive flail segment of the tricuspid valve, he just did the quadrangular resection and he put new chordae. The same goes here. This is a triangular resection, sorry, not like this one. This is a flail part of the posterior leaflet. You can see here also for elongated chordae and papillary muscle, there are multiple techniques. Ruptured papillary muscle, there is the implantation technique. Also, if you have infective endocarditis and ruptured leaflet, you can patch it. As in the mitral valve, no repair is complete without stabilizing the annulus with an annuloplasty ring. Another common reason for tricuspid regurgitation is pacemaker leads. This is the technique mentioned by Carpentier. For me, I prefer to just remove the leads, repair the leaflet if I can, or replace, and put epicardial leads. It will prevent any further damage. But as you can see here, he took the lead and put it through the annulus and then resected the abnormal part of the leaflet and sutured back the leaflet together. The last part of my presentation is regarding replacement. It's a very short part. Tricuspid valve replacement, usually a pledgeted mattress sutures using either an everting suture technique for the mechanical valve or supraannular or intraannular technique for bioprosthesis. The tricuspid valve septal and posterior leaflet are left in place. They usually are left there to preserve the subvalvular structure and help avoid injury to the conduction system, because they demarcate your anatomy regarding the conduction system. Also, the central portion of the anterior leaflet can be excised, only the central portion, and still preserve the chordal attachment of that leaflet to preserve the RV shape. The reason this was mentioned is because there is a concern that the anterior leaflet could prolapse into the RVOT and obstruct the RVOT when you place your valve, especially with like a high profile valve with big struts. Prosthesis options, homograft, which is a cadaveric mitral valve, sometimes used. I only saw a video of it. I have never seen it. I only read it. And mechanical tricuspid valve and bioprosthesis. Regarding the option whether to put a mechanical or bioprosthetic tricuspid valve, it is a gray area with no clear indication. Even in the guidelines, it was not mentioned. But the summary of what was mentioned in Lawrence, that the previously reported poor results of the mechanical valve in the tricuspid position were during the era of old valves. And they were all due to valve thrombosis. You know that the newer valve are less thrombogenic and have less profile and less surface area for thrombosis. So these reports may be not applicable to the new generation valve. Also, compared to the mitral position, bioprosthetic valves in the tricuspid position exhibit longer durability with longer duration of freedom from structural valve dysfunction. However, the thrombus and pannus formation was found to be more frequent in the tricuspid position on bioprosthetic tissue. And it is hypothesized that anticoagulation in patients with bioprosthetic valve in the tricuspid position can reduce the incidence of pannus formation. Another thing that makes me make me lean more on this decision to put a prosthetic valve on tricuspid valve is the advent of transcatheter valves. Like if I put in a young patient a prosthetic bioprosthetic tricuspid valve, in case he had any degenerative valve disease, a valve-in-valve is a less invasive and a possible option. The technical aspect of mitral valve replacement, it's almost similar to mitral valve. Usually your sizing is performed by measuring the intertrigoral distance. The orientation of the valve is critical to be sure that the right ventricular outflow tract is straddled by the two of the commissural posts. It is better to use low-profile mitral bioprosthesis, and you make sure that the subvalvular apparatus is visualized to ensure that there is no impingement of the prosthetic valve leaflet by the subvalvular apparatus. This is a picture depicting how it is done. You can see the multiple pledgeted mitral suture being put on the annulus of the tricuspid valve. That was the end of my presentation. Thank you very much. My resources were the European and American Heart Association guidelines, also Lawrence Cohen book for cardiac surgery and Carpentier reconstructive valve surgery. Thank you very much. And the space is open for any questions. If there are no questions or anything to be added, any information that can be added, we can just, I don't know what's the time, 2:30. We can just start the second lecture, so we catch up with Dr. Hafiz's case discussion. So, Dr. Musallam.
Yes, doctor.
Are you ready?
Yes, I think.
Yeah, you can start sharing your slides.
Okay.
تفضل يا تحب تبدأ.
Transcatheter tricuspid valve interventions. Dr. Muslim Musawi, BJY2 from Saudi Al-Babtain Cardiac Center. I will present transcatheter tricuspid valve interventions today, inshallah. Those are my objectives. I will talk about the first briefly about the anatomy and pathophysiology because it was mentioned. Imaging guidelines and challenges, stages of functional TR, patient selection criteria, percutaneous tricuspid interventions, devices and clinical outcomes, and some of the latest studies on the tricuspid interventions. Introduction. Tricuspid regurgitation is a common finding in patients with left-sided valvular or myocardial disease, often being a marker for a late-stage chronic heart failure with a grim prognosis. Reluctance to perform tricuspid surgery. This is owing to the increase in hospital mortality, particularly following prior left-sided heart surgery. Or initial repair of the tricuspid. In recent year, a growing knowledge with the multiple emerging transcatheter tricuspid technologies among the interventional and surgical committees, with the growing knowledge, they introduced the transcatheter modalities. Pre-procedural screening and multimodality imaging is imperative to understand the tricuspid valve anatomy and plan proper management. So anatomy and pathophysiology. Located between the right atrium and the right ventricle, the tricuspid valve is slightly more apical than the mitral valve. The orientation consists of an annulus and leaflets, 3 leaflets, papillary muscles, and chordae tendineae. The tricuspid valve is oriented at a 45-degree angle to the sagittal plane, facing anterolaterally and inferiorly toward the left side. The annulus of the tricuspid valve is a non-planar structure with a distinct bimodal or saddle-shaped pattern, having 2 high points oriented superiorly toward the right atrium as its superior, and 2 low points oriented inferiorly toward the RV. As you can see here, the dilatation of the tricuspid annulus, it's not symmetric. It has been shown in the studies that the anteroposterior distance increased by approximately 80%, whereas the mediolateral distance increased by only 34%. This is because of greater dilatation along the free wall aspect of the annulus. I think it was mentioned by both my colleagues. This is the same illustration that the dilatations occurs in the free wall of the tricuspid valve, the free wall of the RV. RV, or annular dilatation, and tethering of the leaflets are the 2 main pathophysiologic mechanisms for development of the functional TR. While this is mostly secondary to left-sided disease, it may also be associated with isolated RV disease or pulmonary hypertension. The tricuspid regurgitation that develops through these mechanisms lead to further RV dilation and dysfunction, and more tricuspid annular dilation and tethering, thereby progressively worsening the existing TR. Imaging guidelines and challenges. As you can see here, the TEE taking from the different level with different rotation, showing the leaflets and alignment of the leaflets, the coaptation of the leaflets. Here is an echocardiographic evaluation of the TR. The grading depends on factors, the severity of the tricuspid valve, central jet area, vena contracta, the effective regurgitant orifice area, the visa, vena contracta, also, and hepatic vein flow. As you can see, in the severe systolic reversal happened during the flow in the hepatic veins. More than 10 is severe, considered severe. Of the central jets, and there are other added classification, massive and torrential, which the vena contracta more than 21 millimeter. The TR requires multimodality imaging with 2D transthoracic echocardiography and 3D TTE computer tomography and the magnetic resonance imaging, while TTE and transesophageal are excellent at visualizing the tricuspid valve leaflets, as I show in the image, the first slide of imaging. CT and MRI are superior for accurate assessment of the tricuspid annulus geometry. As you can see here, the geometry, the structure, and the size is more accurate with the CT and MRI. There is a staging of functional TR. There are 5 stages, and the stage depends on the grade of TR, The symptoms: annular remodeling, leaflet coaptation, teeth ring, RV function, and remodeling. And based on that, we move to the treatments. Want to start medical treatment? What is the surgical treatment, and if there is any percutaneous treatment option? As you can see, that at first stage, there's no symptoms, less than moderate, so no treatment, just follow up with echo. The second stage, you start consider to add the diuretics and consider repair if there is a left-sided surgery, so consider repair. And you may consider the percutaneous also repair if there is no left-sided surgery. And the third and fourth and fifth stage, we will speak about severe TR, and if there is a preoperative risk or cardiovascular surgical risk, so the patient may undergo percutaneous transcatheter replacement or repair of the valve. So this is a proposed classification, the same as what I showed you previously, but here in the early stage, there is initial dilatation in the RV and the tricuspid area. Then the annuloplasty may help in reducing in controlling the dilatation. Leaflet approximation and replacement, the orthotopic replacement. So in the annular side, going progressively with more dilatation, lack of leaflet coaptation, also the same options, and replacement maybe later or either heterotopic or orthotopic, depending on the RV function. Patient selection for the transcatheter option should be done by a multidisciplinary heart team to assess the chances of procedural success and clinical benefit. After maximizing medical therapy with diuretics, the cause and mechanism of TR, in addition to the right ventricular function and size, must be evaluated by the heart team. Surgery has classically been considered the first line treatment. However, if after evaluation the patient is deemed inoperable or at high risk, surgical risk, it was demonstrated that the transcatheter associated with the lower all-cause mortality and rehospitalization when compared with optimal medical therapy alone. Selecting the appropriate technique and the device can be difficult, since there are several studies. The studies are comparing the intervention to optimal medical therapy, but they are not comparing intervention to intervention. And this is for this, the choice of the device must be based on anatomic and physiologic features. We have to the approach ideal and complicating factors. For edge-to-edge repair, the ideal factor coaptation defect is less than 7 millimeter. So adequate leaflet mobility, anteroseptal jet, confined leaflet prolapse or fly leaflet, RV lead without primary leaflet obstruction. Complicating factors for the edge-to-edge repair is going the gap more than 8.5 millimeter thick and short leaflets, leaflet perforation, difficult echocardiographic visualization, and the cardiovascular implantable electric device RV lead, leaflet embigment, anteroposterior jet location. As you can see, previously I show, and my friend also showed the free wall enlargement. So when the jet is between the anterior and posterior leaflets, this is complicating factors, while when it is between the anterior and septal leaflets is an ideal factor. Severe leaflet tethering is considered as a complicating factor. So for annuloplasty, the annular dilatation as the prime mechanism of TR plus central jet, no or mild tethering, adequate anatomic landing zone for the anchor deployment. Those are ideal factors. Complicating factors: severe annular dilatation exceeding device size, severe tethering, severe pulmonary hypertension, electric device, implanted electric device, induced tricuspid regurgitation, anatomic proximity to the RCA from the annulus. So here is the algorithm or treatment options. If we have a patient with severe tricuspid regurgitation, optimal medical therapy and adequate diuresis should be for all severe tricuspid patient. Evaluation by multidisciplinary heart team. Some patients are excluded, for example, the end-stage lung disease, end-stage renal disease, severe fixed severe pulmonary hypertension, neurologic dysfunction, non-curable active malignancy, and cardiac amyloidosis. Then we end up having primary TR or secondary TR. So if the pathology is a restrictive pathology or perforation, the transcatheter tricuspid replacement, if the prolapse or flail, the transcatheter edge-to-edge repair, and if there is a lead, either repositioning or removal. If not resolving the TR after repositioning or removal, we can do the transcatheter edge-to-edge repair can be done. As for secondary TR, with isolated annular dilatation with no or minimal tethering, annuloplasty can be a solution. For annular dilatation with mild to moderate or moderate tethering and gap optimally less than 7, the transcatheter edge-to-edge tear may take place if there is severe leaflet tethering and the coaptation gap is such wide, more than 10, consider replacement either orthotopic or heterotopic placement. A percutaneous tricuspid interventions. Now I'm in the second part, so there is I will be talking about the devices and the outcomes and clinical trials conducted on these devices with latest trials. The types of devices: we have leaflet approximation device, we have the annuloplasty systems and transcatheter tricuspid valve replacement, so implantation, and we have the caval aortic valve implantation also systems. Here is a summary to some of the devices, not all of them, sure, but this is the main devices and the techniques used, the access site, the size of the sheet, and the procedural success, and the study conducted, name of studies conducted on the device. As you can see, we have the Trisense, Trialan, and Cardioband, Triapta. They are used for the annuloplasty, and also Millipede system for annuloplasty, and the procedural success is with high procedural success. The axis differs. Most of them transfemoral, but the trial line is the transejacular axis. And there are other devices, cooptation device like the Forma, TriClip. I will talk about the TriClip later on. The TriCasp edge-to-edge technique. The study TriLuminate. We'll talk about this study in later slides. So for the replacement, we have two categories of the replacement of the transcatheter TriCasp valve. Orthotopic, what does this mean? It means that the valve is deployed at the TriCasp valve annulus. Heterotopic, where the valves are deployed in one or both vena cava. So the gate valve, this is a orthotopic valve, is an atrioventricular valved stent that has been developed for the treatment of TR. The first reported use in human of this catheter-guided TriCasp atrioventricular valve was used in the Cleveland Clinic in the patients 64 years with end-stage renal disease with multiple admission for the right heart failure. The TriCasp annulus measured 50 millimeter by 40 millimeter on a focused 4D CT study. The patient tolerated the implantation well and was transferred to the ICU. She stayed there around 29 days and then discharged. Pre-discharge TTE for this patient showed moderate to severe RV dysfunction and mild to moderate TR and paravalvular leak. We have the caval aortic valve implantation, and this is the heterotopic type of implantation, and it is used with severe patients with severe TR and significant venous congestion. The valve in this technique is inserted percutaneously into the inferior vena cava to protect the abdominal vasculatures from elevated venous pressure and systolic backflow from severe TR. The upper valve segment protrudes into the right atrium and the lower segments anchors to the inferior vena cava. The first reported experience with this cavity was reported by Lawton and colleagues in 2011. The valve implantation was successful and the patient's functional capacity and heart failure symptoms improved. Right atrial volume overload and right atrial ventricularization are potential demerits of CAVI. So what is the clinical outcomes of those devices? Here is a summary of the studies and devices done with the baseline characteristics for each study and device. Mostly patients, NIHA class 3 to 4. And the effective the vena contracta width is around ranging from 17 to 12 in some studies, and the effective regurgitant orifice area also from 0.5 to 2.5 ranging. The outcomes, as I mentioned, the procedural successful rate was high in most of the studies. Here are some devices that I would like to to talk about the primary endpoints of each. The tricuspid valve repair system, which this is the Abbott medical device. The study clinical trial named TRILUMINATE. The primary endpoint was tricuspid regurgitation reduction, more or equal to 1 grade at 1 month. Composites of major adverse events at 6 months. I will talk about it in details later on. The Pascal, the Edwards CLASP TR EFS trial, freedom from device or procedure related adverse events at 1 month. TRISYNC system and TriAlign cardio band. Those are the annuloplasty and Maya also, all of them for the annuloplasty. With the freedom, most of them 30 days, all-cause mortality, 30 days. That was the primary point of most of them. There is an issue with the device lead induced TR. So the percutaneous transcatheter tricuspid interventions for lead-induced TR has been investigated using various devices, which I mentioned previously. There is a risk of lead damage after device implantation and potentially embeds further future lead extraction in case of lead endocarditis. This has to be taken into account. This is a latest study presented at the American College of Cardiology this year, I think the beginning of this month, which is the TRILUMINATE study. In this study, it's a multi-center RCT to test the superiority of the TriClip therapy over medical therapy alone. So again, this study is comparing the medical therapy to one device only. There is no comparison between the devices, the different range of devices. So 35, the population is 35 patients enrolled at 75 sites in the US, Canada, Europe, symptomatic severe TR, and at intermediate or greater risk of risk for tricuspid valve surgery. 175 patients randomized 1-to-1 to both arms. The intervention, transcatheter edge-to-edge repair using TriClip, and the control group with guideline-directed medical therapy alone. The outcome was the primary endpoint was the mortality or tricuspid valve surgery, heart failure, hospitalization, and the KCCQ. This is to exactly assess the it's called the Kansas City Cardiomyopathy questionnaires to assess the quality of life of the patients. So the primary endpoint, when it is more than 15 points, significantly improved with significantly improved with the intervention group, which is the TIR group, driven by quality of life points in 49.7% of device versus 26.4% of the medical therapy group, with a significant, very significant p-value. No difference in mortality and heart failure, hospitalization for heart failure, TR reduction to less or equal to moderate in 89% of after the TIR at 1 year, 30-day major adverse events rate was only 1.7%. The time was 1 year and 30 days. For major adverse events, 30 days. The primary endpoint, death, hospital, heart failure for hospitalization for heart failure, and quality of life was 1 year, the duration. At 1 year after the tier, significant improvement in quality of life related to this is the result to TR reduction, and there was no difference regarding the mortality and heart failure, hospitalization for heart failure. Those are my references, and thank you very much for listening to my presentation.
Thank you very much, Muslim. That was a very comprehensive review, and thank you for your hard work. Does anyone have any additional questions to Dr. Muslim or to the group? Okay. Dr. Ahmed is still not with us. We will wait until 3:15 because he is busy in the OR. If by 3:15 he's not around, we will postpone it to another time. Does anyone want to discuss any of the points of the previous discussions during this break, or you are free to add anything? Dr. Mariam?
Alan Faisal.
Yeah.
Sorry, my information about transcatheter, it's very evolving. So I didn't keep track on transcatheter valve replacement. All I know, there is a lot of randomized control trials are done right now to see the effectiveness. I'm sure there will be more information in the near future.
I have a question outside of that topic regarding something Dr. Khulud mentioned.
Absolutely.
One of the options for us during reoperative, especially valve surgery, is minimally invasive. And one possible technique we can use is during fibrillatory arrest, especially fibrillatory arrest, especially whether it's right or left valve surgery. I only attended once. Only I have seen one case where it was minimally invasive through a right thoracotomy, mitral valve replacement, and it was done under fibrillatory arrest. My question is, how would you de-air such patients? For me, de-airing is still not very like the steps exactly during regular cardiac surgery. I'm still like learning them. So how would you do in a fibrillatory arrest where you don't have aortic root vent? You only have your left atrial incision.
That's a really good question. Again, I'm not a minimally invasive surgeon, and I've never seen this procedure done before. But apparently, they can put aortic root, not aortic root, but LV vent through pulmonary vein and through the thoracotomy.
I see. I remember when I attended this case. The surgeon cannulated the SVC and IVC through the right and the right femoral vein and the internal jugular. Also, he did his arterial cannulation through the femoral artery. He induced fibrillation with a device I only saw once during my whole life. It looked very old. He put a lead and he it would, I think it would deliver electrical current to induce atrial fibrillation, ventricular fibrillation. The patient has to have competent aortic valve, so the LV will not distend. And I remember the only thing he used is just he would inflate the lungs until he would fill the LV and the LA with the LV vent. And after final closure of the left atriotomy, he would de-air everything. But I don't know if that is enough or I missed something in the OR. That's why I asked you.
Yeah, I wish if I have an answer for you, but I think for any left side valve disease, you would want to have a proper de-airing. Otherwise, you'll end up having, air in the coronaries, or you'll stay in bypass for a long time just to de-air. So if it's possible, I think it's possible through the right thoracotomy to put an LV vent through pulmonary veins.
I see. I thought maybe someone else in the group saw this procedure before who can add for us.
There is actually a journal of clubs happening. I'm not sure. I will check about minimally invasive surgery. It's in the Eastern Province, but I'll check about the details. I did not register as I'm not very interested in minimally invasive, but if any of you guys, I will post it in the group.
Thank you very much, Doctor.
You're welcome. And Dr. Ahmed is ready. He's logging in.
Ah, great.
أعتذر يا شباب على التأخير. دكتور أحمد ثواني بس ويدخل.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
سامعيني؟
نعم يا دكتور نسمعك، حياك الله يا دكتور.
Good. طيب دقيقة واحدة بس أعمل. باين عندكم الشاشة تبعي ولا ما هي واضحة؟
واضحة يا دكتور.
طيب ممتاز. معليش أول شيء آسف على التأخير في العمليات ودوبنا بنخلص. معليش سامعين صوتي ولا ما حد سامع صوتي؟ عشان أنا يا دوبك سامعكم.
سامعينك يا دكتور، تفضل.
ممتاز الله يديكم العافية. آسف على التأخير في العمليات، لسه أنا حتى ما خلصنا. عموما أنا اسمي أحمد حافظ، استشاري جراحة قلب مستشفى العسكري هنا في جدة. joining them جديد لسه لي شهرين معاهم، فأنا ما شاء الله تبارك الله معظم الريزنت اللي هنا ما أعرف منهم كثير. أعرف أختنا الدكتورة مريم، وأعرف ما شاء الله 4-5 من الريزنت الموجودين هنا. الكيس برزنتيشن اللي حسويها إن شاء الله والأورال إكزام اللي حنسويه، يعني nobody need to feel hesitant ولا إنه خايف من شيء. it's friendly، كلنا مع بعض إن شاء الله. أنا حاطط أصلا الأجوبة حقت الأسئلة عشان يعني إذا حسيتوا نفسكم ما أنتم عارفين بعد ما نخلص حنجاوب حوريكم الأجوبة كلها، حتى لو تبغوا البرزنتيشن بعدين أعطيكم هي يعني for your own reference. اختصار للوقت، في أسئلة حعديها، في جزء من الأسئلة هو المهم، هو اللي يعني نحاول emphasize more time on it. تمام؟ ففي الهيستوري أنا حبدأ الهيستوري وبعد كده نشوف مين يبغى يشاركنا وقتها في المحاضرة. طيب الهيستوري
دكتور أحمد.
نعم.
الله يعطيك العافية دكتور أحمد. it's مريم.
أهلا وسهلا مريم.
الله يرضى عليك، شكرا لك for joining. أحب أعتذر بالنيابة عن الريزيدنت عن اللي حصل الأسبوع اللي فات، بس ما كانوا هم عارفين إنه راح نبدأ الساعة 3. ثاني شيء عشان في request من الريزيدنت بالنسبة للكيس إن previously we're choosing one resident to run the whole case، وحسونا شوي في load على one resident. So if we can like يعني pick multiple residents along the case.
تمام، ترى أنا ما أعرف أسمائهم، أنا حأشوف مين يبغى يجاوب ويشاركني. تمام، ولا أنت تساعدين عاد مين في السينيورز. You pick with me one of the seniors. تمام.
إن شاء الله إحنا we try to keep it volunteer, so whoever will raise his hand في الأسماء we'll go with.
تمام، أوكي، خير إن شاء الله.
Yeah.
Okay, so actually I'll start this the initial presentation وبعد كده نشوف لنا أحد. فالpatient, this is a real patient actually. He was here almost 2 months ago. 65 years old patient. He was admitted to CCU with history of exertional shortness of breath for 3 weeks. His initial ECG was left Mandelbrot block. Echo EF was low, 35%. Akinetic thinned out apex with severe MR, while RBSP was high, around 65. فالكارديولوجي colleague, they called us to assist the patient. طبعا السؤال ده كنت ابغاه مور للجونيور how to approach this patient. فخلينا نعدي السؤال ده. هنا I want somebody to join me here. What investigation imaging would you order to this patient? Anyone want to volunteer?
Can I try?
Can
I answer? Can I answer, Doctor? This is Faisal Ghamdi.
Okay, yes, please go ahead.
This patient is in heart failure. Most probably from the echo findings, maybe due to ischemic cardiomyopathy, especially with the left bundle branch. If it's new, I don't know if it's before or not. I want first to know if it's reversible or no.
Okay.
We already did echo and it showed the thinned apex. I just want to make sure it's viable. Most probably if it's thinned out, it's not viable, but maybe MRI cardiac could help us know. And I want also to assess the other walls viability in case he will go for revascularization.
But before we jump to the viability, investigation, what other investigation do you want to, lab works?
Yeah, sorry, Doctor.
I just want it to be organized and don't miss any points.
Yeah, lab-wise, first I want to see his lactate, how much he's having low cardiac output, is he perfusing his end organs? I want to do for him CBC in case he's having infection or anemia, in case he will need an intervention. I want to assess his renal function, so I will send for renal panel and electrolytes. Also, I'm still, one of my differential is ischemia. I want to do troponin and cardiac enzyme to see if it's really ischemic insult, recent ischemic insult or something that is chronic. That's all in the labs I want to check. And BMP.
So to be organized, you can say CBC, lights, urea, creatinine. If you want liver function test, INR, PTT. And then, as you said, lactate to see if there is any signs of myocardial or cardiac shock or something like that. Okay, what imaging do you want? You said MRI. You jumped to the MRI. We have an echo.
I need coronary angio.
Okay.
And
you said coronary angio or MRI, right?
Yes.
Okay. So I hope it's clear. This is his coronary angio. Can you go through it's fixed pictures? Can you just tell me what do you see?
So I will start from the left.
Okay.
So this is a shot of the right coronary artery. And it has multiple lesions in the proximal part of the RCA. With diffusely diseased RCA and PDA, but he has a good PDA for graft.
Okay.
The next shot is also another shot of the RCA, showing the more clearly the proximal RCA lesions, which are significant lesions, and also diffusely diseased coronary artery, and good PDA, there are no significant lesions, and it's almost the same size as the catheter.
Excellent.
The last picture is of the left coronary artery, showing the LAD and the circumflex. I can see proximal LAD lesion, proximal and mid after the first diagonal, severe lesions with diffusely diseased distal LAD.
It's small. It is diseased down there, but mainly small LAD.
Small, and it is almost half the size of the catheter. The left, the circumflex, he has significant disease at the junction or the bifurcation site to the OM and the continuation of the circumflex with the small OM, and also diffusely diseased. It is jagged. So that's it.
Good. And you said you want an MRI as well, right?
Yes, MRI or perfusion scan to see the viability.
Okay. What is the gold standard actually? MRI or what kind of scan is the gold standard for?
Actually, this concept of testing the viability for reperfusion is a very controversial area.
Yes, right.
Especially that they say that one of the major trials, the Syntax, which showed the the survival benefit of reperfusion, they did not count for viability, if I understand
Absolutely
correctly.
right.
So for me, this is just another point I will use to push either toward or away from surgery for this patient, revascularization. Sorry, not surgery, revascularization.
Revascularization, exactly.
Yeah, or medical treatment.
Yeah.
But which one is the gold standard? I really don't know, doctor. But I know that the perfusion is to show the cellular activity. Is there any metabolic activity? And the viability, they will see the wall uptake of gadolinium.
However, so you asked for MRI, this is the MRI result, okay?
Yes.
They are telling you the mid-anterior septum and distal 2/3 of the anterior wall partially thickened and scarred less than 50%. One, they're telling you the conclusion, moderately dilated LV, anterior wall motion abnormality, severe ischemia, EF is around 25%, or 4 out of 8 of LAD territory are non-viable. Yeah? How would you interpret the MRI result?
So it said 4 out of 8 of the LAD territory is non-viable, and there is severe MR injection 25%. That's on the 3.
Yeah, but usually when there is an MRI to you, usually what specifically you want to see in MRI حتى لو ما أعطيتك الريبورت تمام؟
I want the LAD territory.
طيب لو ما أعطيتك ريبورت قلت لك what criteria in the MRI you want to see to say this is a viable myocardium?
The amount of uptake of gadolinium of the myocardial wall.
قديش the thickness you want?
I don't know really. I only read the report.
في كده certain criteria you want to look at حتى لو ما عندك report to say this is a viable or non-viable. في أي أحد يعرف في الكرايتيريا حقت الإمارات؟ تساعدوا أخوكم فيصل؟ ما شاء الله يعني ما قصر لين دحين مبدع يعني. يعني في واحدة من هنت موجودة هنا اللي هي 50% عشان أعطيكم هنت. لما يقول لك في 50% ولا less than 50% هذا شيء. وفي شغلات ثانية نبغى نعرفها. Anybody knows? حل الصمت على الجميع. خلاص حكمل معاك يا فيصل لين بعد كده نرجع للسؤال ده. طيب سؤال سهل ده هذا كده جبت كده extra point. In this case, what class of recommendation to treat his coronary artery?
It is class 1.
عشان?
He has triple vessel disease. One of them is proximal LAD. Also, he has mitral regurgitation and low ejection fraction.
Low ejection fraction. أجيب لكم إياه بس بعدين نشوفها. طيب. What intervention would you consider? أنت دحين surgeon وعملت الهيستوري حقك وسويت الانفستيجيشن وشفت الكورونري وشفت الايكو وشفت الفايابيليتي and you decide to do the surgery. What intervention would you consider to treat the mitral valve in this patient and based on what evidence?
So what intervention I would give to this patient?
For the mitral. أنت قلت لي CABG class 1 indication. What about the mitral?
I want to see the LV diameter first, whether repair, if it's significantly dilated. But this patient came with heart failure already. I would go for replacement.
You will go. طب معلش دقيقة واحدة. ألو. You will go for replacement. Why?
Because I'm afraid his LV will not recover after revascularization and it will continue to dilate. So my repair will not last long for him and he will have recurrent MR.
That was based on what evidence? إيش الستدي اللي قالت؟
I have only from my reading actually and from my discussion. I have no study actually for this claim.
طب نشوف إذا في حل. أسأل صديق إذا في أحد يساعدك. إذا ما في الكاريون. Anybody want to answer this question? Anybody knows what evidence. طبعا في واحد مريض حقه اللي معايا المفروض اني قتلتها بحث معاه، فلو قال انا ابغى اجاوب ما حخليه يجاوب. اذا في احد ثاني يبغى يجاوب الله يحييه. It's an easy question. في اي احد عرف عن شيء اسمه CTS net trial for moderate mitral valve and for moderate regurg and for severe regurg?
No, actually I have never read it.
طيب خلاص نعدي اللي بعده. How would you quantify the severity of MR? كيف تقول ده severe MR by echo?
The regurgitant fraction.
Okay.
Regurgitant volume.
ممتاز.
An effective regurgitant orifice area.
خلاص كفاية كده. I am satisfied. في كرايتيريا طويلة عريضة بس I'm satisfied with what you say. نرجع بين الإجابة. طيب you decide to take the patient for CABG and mitral valve replacement. Describe your approach to the surgery.
Well, I will do it through a median sternotomy incision. My cannulation strategy will be I will use two single stage cannula in the SVC and the IVC for the venous and direct aortic arterial cannulation. For cardioplegia, I will use antegrade and retrograde cold blood cardioplegia. I will do for him.
Why do you want retrograde?
Better protection and to give it continuously while I'm doing my surgery. Because his LV.
وانت حتعمل كبش طيب حتحط جرافت ما تنفع تعمل منها كارديوبليجيا.
I can give through the grafts, but after I finish my cabbage and doing the mitral part.
إذا خلصت الكبي ما أنت محتاج شيء خلاص عندك أنتجريد وعندك proximal وتعطي في proximal كارديوبليجيا. However, I will not discuss much. So you want antegrade, retrograde,
cold cardioplegia, blood cardioplegia.
Okay.
And
عشان لا ألخبطك أنت قلت لي median sternotomy.
أيوة.
Aortic cannulation, SVC, IVC, antegrade, and retrograde cardioplegia.
صحيح. And I will give him 3 grafts, Lima to LAD, and 2 veins to the PDA and the OM.
تمام. والmitral valve?
The mitral valve, how old is he, Doctor? I forgot what.
He's 65 years old.
I will replace it with a tissue valve.
Okay, good enough. Okay, how would you do the surgery?
First, I will start with my cabbage, the cabbage part. I will first do the OM, then the PDA, then I will put my Lima over the LAD, and then I will go through the Sundergaard groove to do the mitral valve, the left atrial incision to replace the mitral valve without excising the leaflet. I will put prosthetic valve.
Good.
And that's it.
What size? Or how would you size?
I will try it. If I sized it, I will go down by 1 size.
Okay.
Like the ring.
Excellent. Excellent. Okay, so you did your procedure and patient did well. Day 1 post-op, the patient developed VFib. It was witnessed. CPR started immediately. After 2 cycles of CPR, he became sinus. But unfortunately, 2 hours later, developed another VF. And 20 minutes of CPR, the patient regained actually sinus rhythm, but now he's on high inotropic support, higher than this actually. And his urine output started to decline, 5 cc per hour for the last 3 hours. And his lactate shooted up to 12. What is the indication for mechanical support here? In general, what is the indication for mechanical support? Not in this patient, but in general.
Indications for mechanical support, either it's a cardiogenic shock refractory to medical treatment,
How do you define cardiogenic shock?
Signs of reduced end organ perfusion due to myocardial dysfunction.
طيب في كرايتيريا كده معينه ما تقول patient on low cardiac output syndrome or cardiogenic shock. خلينا نقول low cardiac output syndrome. What is the criteria for low cardiac output syndrome?
I don't know the exact criteria, but I would diagnose a patient with low cardiac output syndrome if he had signs of low end organ perfusion with low myocardial function, like if he has low urine output, if he has raising lactate.
طب اساعدك شويه ما قد سمعت يقول لك cardiac index less than ما ادري كم CVB ما ادري ايش.
Through the hemodynamic parameters.
طيب yes.
Yeah, I don't know the numbers, doctor. I'm sorry. I need to review them.
هو لما بتعرف لما بقول تعريف الكارديوجينيك شوك ولا تعريف اللو كاردياك اوتبوت له كرايتيريا هيموديناميك كرايتيريا. في اي احد ثاني يعرف ولا نعصر فيصل كمان في الاسئله اللي بعدها؟
If I remember correctly, it was cardiac index less than 1.8 or less than 2.2 with inotropic support.
Good.
Drop in blood pressure or systolic blood pressure or systolic blood pressure less than 90 for more than 30 minutes, or drop in mean of 30 below the baseline. There was one about the pulmonary wedge pressure less than 15. Oh, sorry, more than 15.
ايوه more than قديش؟
More
You're
than 15.
almost there. لا صح اللي انت قلته ممتاز. معليش مين معايا؟
الوليد الثبيتي.
الوليد الثبيتي. خلاص نريح فيصل شويه ونمسك في الوليد الثبيتي. طيب كلامك صح حنجي له بعدين. طيب what is your option for LV assessed in this patient?
It's going to be VA.
انت قلت لي الحين المريض ده خلينا نقول انه عنده الكرايتيريا اللي قلت عليها for low cardiac output ونحن عارفين انه الاي اف حقه له 25% ودحين على high inotropes والcardiac index less than 2.2 والsystolic pressure barely 90 ولا below 90. So you decided to put an LV assist device. What options do you have?
For short-term mechanical devices, you can use either intra-aortic balloon pump. You can do VA ECMO. There is when you can do it by cath. I forgot the name, but I don't think the patient is candidates for.
Impella.
Impella, yes, correct.
Right. افتكر الكابرس الامبالا امبيلا. طيب يلا شو نديك شيء كده تحطه في راسك سهل.
For the choice, so far all the cases, the similar cases, people have only seen people using VA ECMO. I haven't seen intra-aortic balloon pump being used for since so long time.
You haven't seen intra-aortic balloon pump, so you would jump to the Impella على طول مدري قصدك.
No, not Impella, ECMO.
You will jump on the ECMO before you put an intra-aortic balloon pump? Possibly.
Yes.
قول لي أنا أبغى أحط ECMO. أقول لك طيب. اوكي خلينا بعد نجي الكلام ده. طيب اعطيني وات از الحين انت جيت المريض خلينا نحط سيناريو ده. جيت المريض والمريض بيعمل له CPR. طيب and you decided to put ECMO on CPR. المريض هو مسوي له CPR وما هو راضي يرجع معك وانا قلت لك انه ويتنس ومدري شكله والكلام ده كله. What is the indication for ECPR? أول شيء تعرف شو يعني ECPR؟
No, I forgot.
ECMO assisted CPR.
ما شاء الله. هذا مين ده؟ فيصل ده ولا مين؟
إيه فيصل يا دكتور.
طيب ارجع لي مرة ثانية فيصل. جاك لنا فيصل والوليد. Do you know what is the indication for ECPR?
I only know the name, دكتور.
إيش هو؟
I only know the name. I don't know.
اوكي طيب في any volunteer for the indication of ACPR في كرايتيريا كده معينه. خلينا اديك سيناريو كده اتخيله، انت الكاردياك سيرجن الموجود في المستشفى وكلموك في الطوارئ ورحت وقالوا لك يعني نبغاك تحط اكمو فور سي بي ار. ايش الاشياء اللي في راسك تبغى تشوفها عشان تقول انا ححط للمريض ده اكمو ولا لا؟
Is the diagnosis reversible?
Yeah.
طيب ريفرسبل، بس في اشياء كثير ثانيه. وريفرسبل I would accept.
CPR less some people said in 5 or 30 minutes.
بدأت تمسك الطريقة الصحيح. اوكي.
Any end organ damage؟
ما حتعرف إذا عنده organ damage ولا لا. الناس بيسووا CPR. في أي حد ثاني
maybe recent sternotomy.
هو بدأنا نسمع females. إيش السؤال الثاني؟ إيش
maybe recent sternotomy.
recent sternotomy؟ لا ما هي من الكرايتيريا. بس يلا كمل. What do you think else؟ انتوا بدأتوا صح بكلمة CPR less than 30 minutes أو قربتوا من الطريقة الصحيح. فأنت إيش تبغى تعرف في CPR؟ خلينا نتكلم عن CPR بس. إيش الأشياء اللي تبغى تعرفها في CPR عشان تقول I will do ECMO or not؟ يلا سهلتها.
Duration.
ممكن cause of arrest respiratory cardiac.
أوكي واحد.
Was it started immediately after arrest?
Excellent. Witnessed CPR, witnessed arrest. Good quality CPR. يلا بجاوب معاكم. الايج حق البيشنت تفرق معاك ولا لا؟ لو عمره 90 سنه وبيسوي CPR هتروح تنط تحط تفقع رجوله بكايولات وده ولا تسيبه في حاله؟
تسيبه في حاله.
طيب اذا هل في كات اوف؟ هو طبعا age is not 100 is not يعني solid criteria but there is a certain limit you can argue. ممكن احد كده يخمن لنا يرمي لنا age؟ طيب خلاص حنرجع للانديكيشن اوف ACPR. طيب what is the general contraindication for ECMO on general؟ ترى والله الاختبار يجي زي كده ترى، يعني الاورال اكزام يعني في اشياء يجيكم زي السبوت يعني يسموه شورت كيسز، يبغى اكمو وبعد كده اسئله يعني يخلص. انا لميت قد ما اقدر من الاسئله اللي ممكن تنسال عن الاكمو. بعدين يعني الميكانيكال سبورت هذا بحر، انا بس اخترت جزئيه صغيره من الموضوع ده. Anybody knows what is the general contraindication for ECMO؟ إذا ما حد يجاوب أنا أختار. فين رشا؟ هي معانا رشا ولا ما هي معانا؟ هي الريزنت الوحيدة اللي أعرفها من السينيورز. ما هي في رشا. طيب نجيها بعدين.
I have few only that I remember, but I don't remember all them all. If you don't have a plan regarding after what are you going to do after the ECMO, this is a contradiction. If the patient is not fit for transplant, it's not. So that's one thing. Another, although nowadays with modern circuits you can do it, but if you cannot anticoagulate the patient, I remember this was listed as one of the contraindications in some books.
ممتاز. Good. هي لسه طويلة حنرجع لها مرة ثانية. مين معايا؟ فيصل ولا مين بيتكلم؟ وليد. طيب يلا هذا سؤال سهل. أعطيني 4 type of cannulation strategy for ECMO. سهل السؤال ده أعتقد.
For VA, you can do femoral.
Okay.
You can do central.
Okay.
You can do femoral carotid.
Yes.
femoral axillary.
ما شاء الله. خلاص عديت نجيكم بعدين. طيب mention 5 complication of ECMO. برضه an easy question.
Yeah, thrombosis.
Okay.
Bleeding.
Good.
Infection.
Good.
Limb ischemia.
Yes. طب how to avoid a limb ischemia?
You can do reperfusion catheter.
Good.
To limb. How many did you get?
انت اعطيتني تقريبا 5 خلاص جيت لكم اللسته بعدين. طيب you decide to do peripheral cannulation using FEM vessel. Few hours after initiation of ECMO, the patient start to have frothy secretion from the tube, from the ET tube. What is your spot diagnosis? انت عملت FEM ECMO.
Pulmonary edema, it seems like the heart is against a lot of afterload, so I think, and it's functioning, so maybe the patient is having pulmonary edema.
ايش هو ثاني functioning؟ انت كنت ماشي صح، انت قلت pulmonary edema.
Pulmonary edema, yes. But I'm trying to figure the reason for the pulmonary edema. The only thing is increased afterload or increased after on the heart.
Okay. How are you gonna treat this complication?
Increase the flow.
Increase the flow في الECMO?
I think the heart is overloaded. That's why I'm thinking he's
if you increase the flow, you increase the flow في الECMO.
Yes.
Okay, يعني أنت حاطط FEM يعني وأنت قلت المريض عنده high afterload. تمام؟
أنا ما قلت
الكانيولا في الفيمورال ونفخته فلو زيادة.
And the reason I said that is because I think the heart is overloaded. I want to unload the heart.
Like if you want to unload the heart, if you increase the ECMO flow, you will increase the load on the heart.
Maybe I will put a vent.
أعطيتك clue عشان تجاوب. الكانيولا أنت حاططها femoral artery. It's pushing the blood against the heart. الهارت بيعطيك antegrade وانت حاط الكانيولا بتعطي retrograde flow. تمام؟
I was about to say
you are working against the heart. فأنا بعطيك hint. How do you think you're gonna decrease the flow, the LV distension?
I would say I was about to suggest what just Abdullah said in the chat. I will put an LV vent.
What do you want to do?
Put an LV vent.
LV vent, excellent. This is one solution.
Yeah, and also now that I understand how maybe just letting the heart eject by decreasing the flow. Maybe.
By decreasing the flow?
And increase, yeah.
Good. بس انت اصلا الهارت عندك سك، انت حطيت الاكمو عشان الهارت اصلا سك، فانت ممكن تسوي حاجه to make the heart eject.
Giving him
عشان تساعد عشان تقلل الفلو، انت تبغى المريض يكون عنده good يعني perfusion. اذا انت حتقلل الفلو medically what can you do to increase to inotropes. Good. ايش كمان ثاني؟ انت قلت المشكله انه في increase الافتر لود صح؟ تعتقد ان انت اورتيك بالون بامب تساعد انها decrease الافتر لود ولا لا؟
It decreases the afterload for LV.
طيب وحتساعد ال LV لو حطيت انت اورتيك بالون بامب تعمل vacuum effect وتخلي الهارت.
So the patient will be supported by intra-aortic balloon pump and ECMO?
Yes.
Okay.
Yes. What else do you think? انت قلت سيرجيكال فنت صح، بس هذا خليه شويه، في اشياء قبل تقدر تسويها عشان تساعد. في other options، في ترى كثير options، كثير فوق ما تتخيل يعني، يمكن 10 options.
I cannot think of any other than
طيب
the
في
ones I
أحد
said.
ثاني يبغى to answer this question أو يساعد؟
I think, Doctor, you mentioned the Ambella. That's one another option.
Ambella?
There is, yeah.
Yes. Okay.
Also, atrial septostomy.
Atrial septostomy. Yes. Good.
These are the only two I can think of.
طيب ممتاز. في أحد ثاني عنده إجابة سحرية؟ طيب مين قال atrial septostomy؟ وليد؟
Yes.
طيب ممتاز، يلا نكمل مع بعض، هنيجي للحكاية دي. طيب after 5 days of ECMO, the intensivist called you and said the PO2 from the radial artery gas is around 60 and the PO2 from the femoral arterial cannulation is 100. How would you react to this situation?
So this is the north-south syndrome, and the way you deal with it is by putting another VAV ECMO. يعني but another
على طول كانيولاتك معاك ورايح.
No.
في أهدى شوي.
Initially, I think increasing the flow of the ECMO will solve this issue, but this will put more afterload on the heart and eventually lead to dysfunction.
طب هذا أصلاً إيش معناته؟ إنه إذا بعد 5 أيام لقيت بدأ يصير north south زي ما قلت صح syndrome، هذا معناته إنه الهارت start to eject.
Yes,
تمام؟
but the lung is bad.
Exactly. So you need to optimize the lung. صح؟
Yes.
طيب you can optimize the lung first and you see the response. لو أنت تبى تسوي شغلة temporary ممكن ترفع الفلو في الحالة دي. تمام؟ ترفع الفلو فكأنك we push against الهارت. هذه temporary تصلح ال PO2 في upper extremity. لكن you want to investigate the lung to optimize the ventilation وبعد كده عندك other option زي ما قلت ندخل في الكانيولز. What other options إذا نيجي نتكلم عن ECMO زي ما بتقول ممكن نحط إيش ال other options في الإكمو اللي نسويها اللي يقول other configuration that you can do to help a north-south syndrome.
VAV cannulation. So this patient had initially femoral, so I'll put another SVC cannula with the oxygenated blood.
إيش حتنفعنا هذه الكانيولا؟ حتحط منها oxygenated blood؟
Oxygenated, yes.
ممتاز. وإيش كمان في أشياء ثانية ممكن تسويها؟ العكس حقها برضه ينفع. الكانيولا اللي أنت حاططها ممكن you drain the heart more. So أنت تصير you totally draining the SVC والIVC فخلاص ما في شيء كأنك مريح الهارت تماما. فتخلي الفيمورال arterial cannula هي اللي just pushing the arterial blood. هي شغل يعني ميكانيكس هنا تمام ولا خلينا نقول حتى كمان سباكة plumbing. تمام عندك كانيولا هنا وكانيولا هنا. الكانيولا دي الاس في سي you can push arterial blood عشان الارتيريال بلاد ده كله يروح. المفروض انه ليش ما نحب ليش ممكن ما افضل الحكايه دي انك انت لما تحط كانيولا you're pushing arterial blood انت عندك فينس كانيولا في الرجل ممكن تسحب لك البلد ده ووقتها ايش يصير؟ ريسيركيليشن. متابعين معاي ولا ضيعتكم؟
معاك يا دكتور معاك.
طيب كويس. فخلاص نختصر كده بس قول لي انت جبت السندروم صح اللي هو نورث ساوث سيندروم واعطيتني شويه حلول نتكلم بعدين في الحلول اكثر. طيب day 10 repeated echo showed improvement of the LV function 34 to 40%. What is your strategy to wean and decannulate the patient? مين يبغى يجاوب؟ وليد، فيصل، احد ثاني؟ تعبوا ما شاء الله وليد وفيصل ما قصروا.
You can repeat echo whenever you try to wean down.
So you can, for example, if he is on 2 liters flow, then you can, if the echo is okay, you can wean down to 1.5, for example, and then.
معلش أول شيء عارف باسمك مين معي؟
آيات.
آيات. طيب أباكي كده سيستماتيك، أنت بدأتي بداية صحيحة بس أباكي تقولي لي خطوات كده. أنا الحين قلت لك إحنا عدنا الإيكو والال في امبروفد، قولي لي كيف بالضبط أنت you gonna wean until you decide to decannulate.
So if he's, for example, in 2 liters, then I'm gonna see the vitals. If the vitals are okay, echo is okay, I'm gonna go down with the flow of 1.5, for example, and then assess again. If the patient is holding hemodynamics, I can repeat the echo the next day, for example, and assess again, and I can decrease further to 1 liter, for example.
Okay.
Yeah, and reassess. This is what I've seen they are doing here in ICU.
You're gonna go معلش دقيقة واحدة. أروح. أيوه. موجود يعني في المكتب هنا. نعم. دقيقتين وجه، في شيء ضروري مرة ولا؟ طيب أوكي. تمام. Okay, continue. معلش I have to leave in 3 minutes.
Yeah, so this is what I was saying. Gradually weaning down with echo assessment and clinical assessment and hemodynamics of the patient.
Okay.
Yeah.
في criteria معينة كده you want to fulfill until you go down. أنت ما go to down, you said you go down to 1 liter.
For example, from 2 to 1.5 and then to 1.
طيب. Before you go to 1 liter, would you want to assess anything else? Would you do anything else? ما عندك risk of thrombosis كده لو نزلتي بالflow very low? Want to do anything before you do that?
Well, the ECMO assessment and the oxygenator assessment is important. We have to check on them as part of the routine assessment daily. If there are any clots there.
Okay, you need to go with the ACT. You're going to give heparin to go with the ACT to above 300 or 200 to make the flow to 1 liter. Before you go down with the flow to 1 liter, لازم ترفع ال ACT. تمام? You start heparin infusion, ترفع ال ACT. You go down with the flow, and you keep the patient, and you repeat the echo. تمام? وبعدين, if you say if he's in 1 liter and you're happy, what is your strategy to decannulate?
Well, if I'm happy with the hemodynamics and the patient is holding and blood gases are okay, ACT is okay, then we can يعني clamp the clamp for a while and see and reassess.
You cannot declamp if you have passes into the sharia. Would you take it on
clamp, not decannulate. Clamp first for a short time and then reassess.
I wouldn't clamp وخلي cannula جوا تمريض clamp. If you want to decannulate, are you going to take him to the OR? You're going to do it bedside?
Well, for me, I will take the patient to OR. I'm not going to do it in ICU.
Excellent.
Yeah.
طيب ممتاز. أنا للأسف I have to go back to the OR. تمام؟ معليش مريم، أنا نفسي آخذ وقت أطول لكن ما مداني أكمل. تبغوني أشارك معكم المحاضرة بعد كده تراجعوا الأجوبة؟
نقدر الأسبوع الجاي يا دكتور يعني نكمل ولا صعب عليك؟
لا ما عندي مشكلة، إن شاء الله ممكن أرتبها الأسبوع الجاي. وتقريبا وصلنا خلاص تقريبا لآخر سؤال الوينينج، بس أنا كنت بتناقش معكم أكثر عن الأجوبة والكلام ده، بس سوري يعني جاني اتصال I have to go back to the OR.
والله احنا ودنا نناقش يا دكتور، فإذا نقدر نكمل الأسبوع الجاي.
ممتاز. خلاص لو تبغوا ولو تبغوا ارتب الاسبوع الجاي الساعه 3:30 تقريبا بعد ما تخلص مثلا الاورال مع اللي يكون موجود اناقشكم في الاجوبه. تمام؟
ما في مشكله. انا
على
ودي
خير ان شاء
صراحه.
الله.
شكرا يا
شكرا
دكتور، ما
جزيلا
قصرت.
وفرصه سعيده، وان شاء الله باذن الله ارتب مع مريم اجيكم ان شاء الله الاسبوع الجاي نراجع الاسئله دي كلها. تمام؟
جزاك الله خير يا دكتور.
يا مرحبا، السلام.